Awesome. And we're live. Welcome everyone to the Med Matrix Method podcast, where we talk about health, wellness, functional medicine, how to just be a healthier, longer living person overall. We're joined by the wonderful Dr. Rose. Dr. Rose, thank you so much for joining in today.
Happy to be here.
Yeah, me too. So real quick, none of what we're talking about today is medical advice. This is for educational purposes only. If you've been listening to the podcast, thank you. We're so excited to have you. We are starting to go live so you may be watching this live right now, actually. Pretty much it's going to be Tuesdays and Fridays around 4. So if you're interested, want to join live, catch us then. Today, we're going to be talking about a couple fun things. Number one is going to be SIBO, going in depth on what SIBO is, how to treat it, what we do, the difference between functional and conventional medicine. Then we're going to be talking about menopause, which we see a lot of ladies for at the practice. So we're going to start off with SIBO. Dr. Rose, you're actually kind of a SIBO expert. Why don't you, for those who don't know what SIBO is, give a definition of SIBO?
Yeah, happy to. So it's SIBO, stands for small intestine bacterial overgrowth. There's also SIFO, which is small intestine fungal overgrowth, but for the purposes of this conversation, we'll stick to SIBO, which is probably more common. SIBO presents like IBS, or irritable bowel syndrome. So clinically, people who have SIBO may experience constipation, they may experience diarrhea, they may experience alternating constipation and diarrhea. Almost in my clinical experience, almost 100% of the time, they have abdominal bloating. So they feel physically uncomfortable in usually the mid or lower abdominal area. Usually doesn't matter what they eat. It's just kind of physically uncomfortable. So the thing with SIBO is that because it presents like irritable bowel syndrome, historically, irritable bowel syndrome is like what they call a diagnosis of exclusion. So somebody goes to the gastroenterologist or their primary care and they say, I'm having these bowel issues. I really feel kind of gassy and bloated all the time. And if they go through the whole workup at gastroenterology and they get a colonoscopy and they see that they don't have anything more serious like Crohn's disease or colitis or cancer, then they say, well, it's irritable bowel syndrome, and maybe they're given like Wellbutrin or an antidepressant, or maybe they're told to take Miralax, which is an over-the-counter laxative. And then they're kind of sent on their way. And again, irritable bowel syndrome might be a whole nother conversation, but the issue is that because they present so similarly, some people might have IBS, but a lot of those people who are just given that IBS diagnosis actually have something functionally out of balance. And that's SIBO. So what it is that in the small intestine, we have microbes, right? We have like the microbiome that we hear so much about. Those organisms are supposed to be there, but only in certain levels, only a certain amount. And various things can trigger this. But what happens is that those organisms become too many in number. So they're supposed to be there, but not that many. And then when something triggers it, there's this overgrowth. So you have this overgrowth of anaerobic organisms that output hydrogen and or methane gas. Mm-hmm. That's what causes the issue. That's what causes gas, bloating, excessive belching, again, the bloating, and then maybe constipation, maybe diarrhea, depending on the type of organism. So it really is a perfect example, I think, of like the need to dig deeper and not just throw a laxative at it, not just throw an antidepressant at it, because you really need to see, is it IBS? Is it SIBO?
How do you test for SIBO? How do you know if you have SIBO?
So one way that is not ever really done, and it's not really realistic for anybody is a small intestine biopsy. That doesn't happen. What is very easy to do is a breath test. Some hospitals will do this, although that's a little cumbersome to go through the hospital system to get it. It's a very easy at-home test. It's a breath test. And what it does is it measures levels of hydrogen and methane gases. So people receive the test kit at home. The instructions are very good. There's a whole day of prep for it. And then they basically are exhaling into these vials and they mail that back to the lab. We receive the results, and then it tells us if those levels of hydrogen and or methane gas are over a certain level, telling us if it's a positive or negative for SIBO.
Yeah, this might be a dumb question, but does your breath smell when you have SIBO?
No, it doesn't. It's a good question. No, it doesn't smell. There is a third gas that there's one lab that I know of that tests for hydrogen sulfate. And that's kind of like a third type of SIBO. And that is people who have that type of SIBO, like their gas, their farts are like really like smell like eggs. It's sulfuric. Okay. Sure. But other than that, no, you don't have, it doesn't smell.
Gotcha. How do you get SIBO? Right? Because we see so many patients who have GI issues. How does one end up with SIBO?
So there's different triggers. Sometimes somebody had an episode of food poisoning, like maybe they were traveling internationally, maybe they just, for whatever reason, they ate at a restaurant, they got food poisoning. And so in their recollection, they had some GI bug for a while. And they got over the GI bug, but basically that triggered this overgrowth of these microbes. And probably for months or years, they basically have had this overgrowth, but it's been undiagnosed. More commonly, it's at some point in childhood or adulthood, they had basically a diet that was relatively high in sugar and processed carbs. That can increase your risk. Being on proton pump inhibitors, medications like omeprazole, famotidine, for years can also increase your risk. Sometimes it's actually anatomical. It's literally the way that the small intestine, which is just a really, really long tube, lies on top of itself. If there's like kind of certain kinks, it's just the way that you were made, you're just more prone to it. It's almost like these little pockets of microbes don't circulate enough. They kind of, they're kind of stuck and they just produce gas, and it can become problematic. I don't know if I said antibiotic use. Did I say that? High sugar diet. Again, as a child and or adult, say somebody had a lot of ear infections as a child, they were given lots of antibiotics, that's going to increase your risk.
Man, so these are all common things a lot of people go through. Like, how common is SIBO? How many people are walking around with an IBS diagnosis that actually have something like SIBO?
I don't have like an exact number, but I think a high percentage. So there's various studies that I have read in the past. It's maybe 60 to, depending on the exact study that you look at, 60 to 70% of people who think they have IBS were given a diagnosis of IBS. It's actually SIBO.
Really? Wow, because SIBO's treatable, right?
It is treatable, exactly. And that's why, IBS is too, but in actually a different way than SIBO. So SIBO is an infection. It's an overgrowth of these organisms, which most of them are bacteria. So we really do, it does require an antimicrobial approach. And this may, I don't know if you were going to go with this with your line of questioning, but there is kind of like a conventional medical approach, and then there's more of a functional medical approach. But
how do you treat SIBO? Is it just more antibiotics? Like how?
It is antibiotics, but the way that I talk to my patients about it is that we have to approach it, or I like to approach it with phase 1 and phase 2 of treatment. And so phase 1 is antimicrobial, but you have options. You have options of doing kind of the pharmaceutical antibiotics, which can be quite effective, or you can do like a botanical. They're pretty potent antimicrobial herbs. So things like oil of oregano, berberine, garlic, those are all botanical, but they're not wimpy. They are pretty potent. So I just give people the options, the pros and cons, and that has to happen before we then move to phase 2. And phase 2 is, I think, where conventional medicine falls short, because if somebody is treated again in the conventional medical model, they're given a pharmaceutical antibiotic, but then that's it. Then they're just kind of, there's no follow-up support. There's no phase 2. Phase 2 is making sure that you prevent a recurrence, you maintain kind of that new healthy microbiome, and it's individualized, right? So depending on if the person tends towards diarrhea, we're going to use certain tools. If it's more constipation, we're going to use different tools. Some of that might be nutrition, kind of avoiding certain foods, at least in the short term. Across the board, you don't want a high sugar diet. That's just going to kind of increase your risk of having a recurrence. And then different nutraceutical, some medications that can kind of, again, start to heal the gut, lower inflammation, improve the absorption of nutrients, all these things that are basically sequela of having SIBO, and usually having had SIBO for years. So we do all of this work so that we can heal the gut and prevent a recurrence. And that's what I don't see happening from the few conventional medical people who are actually treating SIBO.
Gotcha. Okay. But it sounds like we go to conventional medicine, they're very rarely finding it. Is that right?
Some I'm happy when somebody comes back and they say that their gastroenterologist actually is recognizing it, treating it, doing anything with it. Only a small percentage, I would say, of primary care providers have been trained in it to even know what it is, recognize it. It's I guess you could say, relatively new discovery within gastroenterology, like within the last 15 years. So people who were trained prior to that probably didn't get it in medical school. I don't know currently, to be honest, if it's now being taught to, people going through training now.
Okay, gotcha. All right. So obviously in functional medicine, you see a much lower volume of patients than like a primary care would. Like on a busy day, you're probably seeing 7 patients. When was the last time you actually saw a patient who's dealing with SIBO?
Oh, yesterday.
Okay. So by the
way, I saw 15 people yesterday, not 7. But
okay, wow. Well, okay, you probably had a lot of follow-ups then.
I did.
That's a busy day.
Yeah.
That's crazy. Okay, can you walk me through you don't have to do a last patient, but just a memorable SIBO patient and the care plan they did and what they had gone through and the results they got through functional medicine.
Yep. So this one always stands out to me. This was a woman who is early 60s. And she had been dealing with chronic constipation for literally decades. And she was married to a physician, not a gastroenterologist. I don't remember his specialty, but I know it wasn't gastro. And had been put on laxatives for decades. So that was the only way she could have a bowel movement. She was bloated, but that she had just come to think of that as that was just how it was. That was her normal, didn't really know any other way. It had gotten to the point, I think basically I saw her shortly after she retired. While she was working as a bookkeeper, her health, that aspect of her health was just back burner. She just kind of dealt with it. She took her laxative, whatever. She retires. She decides it's time to kind of focus on her physical health a little bit. So she comes to me and had never heard of SIBO. and we ran a breath test, and her, again, standard breath test will look for elevated hydrogen, elevated methane. Her methane levels were really high. So methane, usually, including in this case, correlates with constipation. So her methane was really high. What happens with that is that the methane slows down the motility of the intestines. When this motility slows down, you can't poop. And then when you can't poop, those microbes build up even more, producing more methane. So it's this vicious cycle. I put her on 2 antibiotics. The standard one is rifaximin. It just targets the small intestine. It doesn't disrupt the microbiome in the colon or the large intestine. And then I also, because she had elevated methane, I added a second, more old school antibiotic, which is neomycin. 2-week course. She had improvement almost immediately, and that varies. Some people it's immediate, some people it takes a week, some people it takes longer. So basically it was like the first time, and I'm not making this up, the first time in decades that she was having bowel movements. I think maybe for her, she was going from really not being able to go at all on her own to not being on the laxative, but having a relatively healthy bowel movement every other day.
Wow. That must have been huge for her. Jeez.
It was huge.
Yeah.
And so I think what I usually do, if somebody has been dealing with it for that long, I repeated we did another 2-week course, just to kind of really make sure that the infection was gone, the overgrowth was diminished. And then we moved into phase 2, right? So for her, the goal is let's maintain the motility. Like we just need to get her. And when somebody is on a laxative chronically like that, the intestines forget how to move themselves. They lose their own knowledge basically of muscular contraction because they don't need to use it anymore. The laxative's doing the work. So we have to kind of retrain. It sounds a little funny, but almost like retrain the muscle memory for her intestines. And so again, some nutraceuticals. I don't remember the exact details of what was involved with plan 2, but fiber, magnesium, like just kind of keep things going and really reserving the Miralax for just as needed. So that was a success case.
That's a good one. That's a good story. Yeah. Just curious, because her husband, do you say her husband was a physician?
I think I never met him, but I mean, obviously he was really happy for his wife and happy to have her feeling better. And I think pleasantly surprised. Yeah, that's really interesting. So what, I guess how often are you seeing SIBO with IBS patients? Is that the 40, or no, you said 60%, right? 60 to, so this is not in my own practice, but just what the research shows, that 60 to 70% of people who have been given that IBS diagnosis, it actually is SIBO.
So everyone who comes into the practice who has IBS, are you doing a breath test?
No, because again, this is such a personalized medicine. I definitely will, offer it, but most people that come in have like multiple things going on. If gut health is their priority, or that's kind of the biggest issue for them, and I strongly suspect that it's SIBO, I will order a breath test. The other gut test that I order probably more frequently because it covers more bases, not just SIBO, is the GI map with zonulin. And that is not a breath test, it's a stool test, but it does show if there's certain bacteria are elevated, including some bacteria that are methanogenic, the organisms that produce methane. And so I can kind of infer from that test if somebody probably has SIBO matched with their symptoms, their clinical presentation. And that one, again, because that one will tell me if somebody has a parasite, a fungal overgrowth. It just kind of does more. And then once in a while, I will order both, both the GI map and the breath test.
Gotcha. So how does something like SIBO or IBS, which we know is more or less a cover-up diagnosis play a role in the gut-brain axis?
Yeah, I mean, a fair amount. There's the leaky gut theory. So that is leaky gut. I will try to be brief in that description of that, but that is quite frequently goes along with SIBO. The idea sometimes that SIBO causes leaky gut. So if you have this bacterial overgrowth, there's a lot of kind of imbalance in the gut level, including higher levels of inflammation. When there's inflammation at that gut level, the cells that make up the lining of the intestine, again, they become inflamed and they kind of pull apart. And what we're talking about is tight junctions. So tight junctions are like gates between two cells in the intestine. If those get inflamed, that we lose the tight junction, things can get into the bloodstream that aren't supposed to get into the bloodstream, triggering an inflammatory response anywhere and throughout the body. And that often is in the nervous system. So it can affect the brain and it can affect mood and it can affect everything. So brain fog, anxiety, like anything having to do with the nervous system, if your inflammation level has gone up, all of that can be involved.
Gotcha. What can happen when the gut-brain axis is messed up?
Well, lots of things. I mean, you get, when the gut-brain axis is messed, you mean when that happens, when there's like a leaky gut process, or just when? What do you mean when it's messed up? Well,
like when the gut-brain axis. So when we talk about like the gut-brain axis, is that just effectively leaky gut?
It's often leaky gut. I think the way that I think of it, we do throw that term around, and I think of it a little bit more that we have part of our brain is actually in the intestine. It's called the enteric brain,
okay, gotcha.
Which I think we've talked about before. But it so we think of the brain as being up in the skull, but actually a good chunk of a lot of the brain is actually literally in the gut, and so it's almost like they're so interwoven. So the obvious connection is for some people, when they're anxious, like there's performance anxiety, there's like you're about to do public speaking, you're going on a first date, your stomach starts to, you start to get butterflies, you start to clench. Some people actually have to run to the bathroom. That's like your classic example of how emotions or the nervous system is literally affecting your gut.
That's really interesting. Weird question again. So if I get punched in the gut, could I get a concussion or like a brain damage?
Like a brain. Not in the classic. That's a good question. Not in the classic definition of traumatic brain injury or concussion. But yes, but it definitely affect the nerve. Yes, it could affect you neurologically.
Gotcha. So people who are eating, I'll just say it, shitty foods, putting bad things in their body, not getting normal bowel movements in, they're going to be cognitively affected by that.
Oh yeah.
Wow.
Brain fog at minimum.
Really? Okay. How often with patients who are dealing with like cognitive issues is it also related to the gut?
Probably a high percentage of the time. Again, I can't speak to actual, I don't have any studies right here, but just in my own practice, I always say that, it's a cliche that like everything starts with the gut, but it's actually a cliche that I believe, because I think that, if things are out of balance, if you're not eliminating properly, you're constipated or bloated all the time, or on the other hand, you are one of my patients who can't leave the house till 12 noon because you have to be right next to your toilet, like all of those things, like that's going to affect everything else, all other systems.
Okay. Can SIBO relate to diarrhea?
Yeah. So just like with IBS, we talk about IBS-D, diarrhea, IBS-C, constipation, and mixed. We have the exact same thing with SIBO. We have D, C, and mixed. yeah, it really kind of depends on which organism, the overgrowth of which organism. And that because certain organisms put out hydrogen, certain ones put out methane, and depending on, and again, if you have mixed, you probably have elevated levels of both.
Gotcha. What subsequent problems are related to diarrhea, and what subsequent problems are related to constipation?
So diarrhea, you're often going to be losing a lot of beneficial microbes, right? A lot of beneficial bacteria, and some level, I would say, of kind of malabsorption. You're just not getting, things are just kind of moving through you too quickly. And all the, again, systemically, all the results of not having a healthy microbiome, and that's going to affect, we're just learning more and more, everything from, again, nervous system to even hormonal implications of when your microbiome is off, and immune strength as well. And then, and I guess if it's really diarrhea, you're probably going to be relatively dehydrated. Constipation, which is probably more common in at least this patient population, you're not fully detoxing. You're not really able to, your liver isn't able to, your liver does its job, but then things get stuck. So including even like estrogen metabolism, and all the other sex hormones, like, there's certain pathways where things are supposed to kind of get processed through the liver. So this is any medication that you take, but also your own sex hormones. If those can't be bound appropriately and then eliminated through the stool, they end up kind of recirculating. And so, and again, in the case of estrogen, you get estrogen dominance symptoms because it's estrogen that was supposed to be bound up and pooped out, and it's not. And so you kind of get too much estrogenic effect. And I see it with, as we've talked about on this podcast before, with mycotoxin or mold exposure and toxicity, with parasites, like all of that. If somebody is not able to eliminate through the bowels, which is our most efficient mode of detoxification, then they're not going to be able to handle exposure to mold the way that somebody who's having regular bowel movements is. If somebody does have a parasite, you can't put them on a parasitic cleanse until you get their bowels moving, or else it's just going to backfire.
Gotcha. Okay. Man, so it's a problem because diarrhea and constipation, these are symptoms, right? So when you give someone a laxative,
exactly,
right,
that's so common. I can't tell you the number of people that say whatever they went to their doctor for, gut related, or gastroenterologist, they were put on a laxative.
Jeez. When you're being told by your doctor to take a laxative, how often is that just the best solution for you versus there's actually there's a root cause reason to why you're constipated?
I think there's almost always a root cause. And even if it's, if it's lack of motility, if your bowels are as people age, they often kind of lose some of that natural motility gut wise. There's still kind of better ways to optimize that and manage that rather than, in my opinion, than a daily laxative. There's ways to kind of promote your body's own motility, essentially. If we're trying to figure out, we're still doing kind of root cause medicine, we're doing the testing, we're kind of trying to figure out what's going on with this person, why are they chronically constipated? And in the meantime, if not given any support, this person is going to have a bowel movement maybe once a week. That's the time where in the short term, take the laxative, right? Like just to get us through till we know more, till we can kind of get the answer. Otherwise they're going to become impacted. They're going to go to the emergency room, and that's not fun.
Yeah, totally. What happens when something like SIBO goes unaddressed for like 10 years, 20 years, like this patient you saw?
You do start to get the systemic things. You do start to get, and there's all sorts of theories, kind of, but what there is inflammation essentially, and that we see inflammation show up all over the body for different people in different ways, but oftentimes the digestive symptoms are going to get worse. You're going to get some of these sequelae from having chronic constipation, having chronic diarrhea, malabsorption of nutrients, etc. But then you're also going to get, whether it's inflammation that's affecting the nervous system, the musculoskeletal system, all of that's just going to kind of continue to get worse. So, yeah. I think that's.
Are there any symptoms that are hard fast? Like, I am 99% certain this person has SIBO.
Chronic bloating.
Chronic bloating. You're like, okay, this person has SIBO.
And what I will do is if I am not totally sure, I will put them on what's called a low FODMAP diet as an experiment, not as a long-term treatment.
What are you looking for? So if you put them on, okay, you think someone has SIBO, you put them on a low FODMAP diet. What are the outcomes that give you kind of insights to what's going on with
their bloating goes down? So the classic foods that are highest in these difficult to digest starches, which is what FODMAPs are, basically they go on a trial of eliminating those high FODMAP foods. If they come back to me and they say, wow, I am like 85, 90% better. I haven't changed anything. I've just eliminated garlic, onion, apples, pears, these other, whatever else is on the list.
That tells you they have SIBO?
That tells me that tells me that they might just have some people, again, this is that enteric brain where it's all tied together. That enteric brain, they're highly sensitive, essentially. They're highly sensitive to those high FODMAP foods. That doesn't necessarily equal SIBO.
Gotcha. Okay, so for someone at home, if they're like having bloating, go on a low
FODMAP. They could try a low FODMAP, yep. The app that I tell people to go to is put out by Monash, Monash University. I think they are in Australia, and they kind of came up with the low FODMAP diet, and they have an app that is really helpful. So if somebody's wondering and they want to just try that first, eliminate those foods, and then see, it's not a diet that's meant to be forever. It usually it's like a trial. If it seems like it's effective, most people are able to end up with a modified version. So you don't have to continue on this restricted diet forever. I don't like recommending restricted diets as a forever thing, but it can be a tool. And then people usually end up where they can just, there's a few foods they might rarely want to eat in excess, but otherwise they can kind of figure out what works for them.
Gotcha. So correct me if I'm wrong, but didn't you say garlic was a natural remedy for SIBO?
Yes, it is. Yes, it is it's an antimicrobial plant. And so what I'll do is if somebody says, I want to treat SIBO with botanically, I will ask somebody, how do you tolerate dietary garlic? Like, can you eat garlic and do you feel fine? And if they say, yes, it doesn't bother me as far as I can tell, then, it can be included in that protocol. If somebody says, no, I really don't, I either get heartburn, I get bloated, then I just won't include it in that protocol.
Gotcha. All right, I'm bouncing around a little bit here, but let's wrap up this question. So someone they have bloating, they do a low FODMAP diet, which they can do through that app you just mentioned. Mm-hmm. They're still bloated. Now you're like, okay, this person probably has SIBO.
Most likely has SIBO, yeah.
Okay, then you do a breath test, or then do you go right to like a
Yeah,
SIBO?
So I think of it as like a flow chart. So I give people the option. It technically can be a clinical or like a presumptive diagnosis. So we don't need, and this is true like within any field of medicine, gastroenterology, functional medicine, we don't need that breath test result to make the diagnosis. I can clinically make the diagnosis, but I offer it to people. So the first decision is breath test or no test. Breath test, we come back, we see if it's positive or not, we proceed. If they say, you know what, I've just been feeling miserable for so long, I don't want to take the time to do the test, let's just start. Then the decision is herbal antimicrobials or pharmaceutical antimicrobials, antibiotics.
How do you help patients decide? Okay, am I going the pharmaceutical route with this, or am I going the more natural route with this?
I have seen, after probably treating hundreds of people in this exact scenario, I've seen both work. I think for the majority of people, either option would be effective. Some people really just don't want to do conventional antibiotics no matter what, and they just want to go natural whenever possible. Great, we'll start with the botanical ones. Other people say, I just haven't had good luck in general with herbs, with plants, so I just want to go with the pharmaceutical. Great. Sometimes it's a matter, like the botanical or the herbal protocol lasts 4 weeks. The pharmaceutical is 2. So sometimes, I don't know, somebody's going to be leaving the country in 2 weeks and they don't want to deal with taking things with them on the flight. So it's customized.
Yeah. How effective is the botanical versus the pharmaceutical approach for SIBO?
It's been studied, and it's and again, in my practice, it's usually just as effective. I have seen it go both ways. We've tried the botanicals, doesn't really work. We go to the pharmaceutical, it works. I've also seen the reverse. I've seen that people don't really respond well for whatever reason. They either have side effects with like cramping, or they don't find that the pharmaceuticals are effective. The botanicals work. So that's why I feel fortunate to have a large toolbox, because everybody's different. Everybody's digestive systems are different, and it's really nice to not be limited to just one tool.
Yeah, it's pretty scary to think of like how different. Every day I just learn more about the medical system and medicine, like going to your doctor with bloating and gut issues, and then they either refer you out to a gastro, which is then another 3-6 months to get in, if that. Then it's like, okay, they just diagnose you with IBS, then give you a laxative, opposed to actually trying to figure out what's going on, like using the low FODMAP diet and then reasoning from there, and then giving them options to treat the root cause of these issues. So really interesting. Last question to wrap up the gut health, SIBO, IBS talk before we move on to menopause. What is your opinion on antibiotics? Because I was raised by a mom who was kind of always more natural, I could say granola mom. So I was always thought like antibiotics are bad, but sometimes they are necessary. You got strep throat, you got to take antibiotics. What's your opinion on that? Like, when are antibiotics actually a good thing, and when are they not? And why are they bad?
Well, I think, they're life-saving. So they've kind of radicalized people are living longer and, surviving childhood diseases now in a way that they weren't 100 years ago. So I don't think we can overstate kind of public health-wise the importance of what antibiotics have done. They have, been overprescribed. And so we have, some antibiotic resistance, et cetera. I think it depends on the situation. I think that what's been done is it's been the go-to. People are just, they were just put on antibiotics for everything, didn't even see if it was a viral infection or bacterial. It was just, here's your antibiotic. And that's kind of how we ended up in this situation. I do like using them when in the right circumstances. So when, for example, we know we suspect somebody has SIBO, I like having that pharmaceutical option of a pharmaceutical antibiotic. Or if there's a different type of intestinal infection, H. pylori, for example, I like having the option of using short-term antibiotics. If somebody has acute Lyme or another acute tick-borne infection, doxycycline is appropriate. So there are definitely times, but again, large toolbox. There's some really great botanical and, botanical antimicrobials that are very potent and actually quite effective. So I don't know if that answers your question, but I guess used judiciously, I do think that they serve a role.
Okay. Yeah. Thanks for clarifying. That's good advice. And that's the thing. You go to a conventional doctor, you might never even be told of another option,
Right.
So appreciate you kind of sharing some insight there.
Yeah.
So, all right, that concludes the, talk about SIBO, IBS. If you're live with us right now, you're listening to the podcast, you want to work with us as a patient, go to medmatrixusa.com, send us a DM on social media, and click Get Started if you're on the website, and you can book a call with the patient coordinator. With that said, thank you guys for joining. We're going to be moving into talking about menopause. So if you're just joining us now, this is the MedMatrix Method podcast. We're live currently. If you're watching to a recording of this, you can catch us live Tuesdays and Thursdays after 4. So to kick us off, and by the way, everything we're talking about, none of this is medical advice, simply for educational purposes only. So Dr. Rose, why don't you give us some context on what is menopause? What is it really? So yeah, let's go.
Okay. Well, it is an area of, I guess, medicine that has been sadly kind of ignored, dismissed, passed along by medical providers in general. Hopefully that is changing. I think we're having a little bit of a moment with some, social awareness around this stage of a woman's life. Perimenopause are the years leading up to menopause. So perimenopause can last 10 to 20 years. It can start as early as age 35 for some women. And perimenopause is when our sex hormones are basically fluctuating. It can vary for every woman, but it can be one day, 1 week, 1 month, estrogen is really high, and then maybe the next it's really low, and it's kind of all over the map. And a woman's going to feel that. She's going to feel those fluctuations. Menopause is actually an event. Menopause is technically 12 months since you've had a period, and at that point, your body, the ovaries are no longer making estrogen and really no longer making progesterone. And that's kind of like a hard stop. So as some people describe it, it's a little bit like falling off a cliff. So those are kind of the technical definitions.
Gotcha. Why does menopause just hit some women so hard, just completely change their life?
Yeah, I mean, that is a true statement. I think some people, some of my patients, even speaking to them kind of retrospectively, like a woman who's say 70, and I ask, well, what was menopause like for you? Some women will say that it was miserable. They stopped being able to sleep. The hot flashes were awful. And they were depressed. They gained weight. And then some women are like, it just kind of, my periods stopped and it was just uneventful and nothing really changed. I think there's a lot of things that go into it. Some of it might be somewhat genetic in terms of, we always like to ask, like, do you know what it was like for your mother, for your sisters when they went through the change? And other times I think it does tie into things like your ability to eliminate, to detoxify. So what's happening with kind of estrogen metabolism at the level of the liver, and if somebody chronically constipated, they're going to probably have more estrogen dominant symptoms. So more PMS, more heavy bleeding, maybe all of that. So other aspects of a woman's health play a role in how kind of what that transition is like. But I think a lot of it's just, we are all such unique beings. We have different hormonal makeup, and it's not necessarily, we always say perimenopause, menopause, it's not a pathology, right? It's like a normal part of, it's a normal stage. It doesn't mean that we can't support the woman's endocrine system and kind of make some adjustments, but there's not really a disease here.
Gotcha. I guess why, before we get into like best practices, what you can do on your own, how we help patients, or how functional medicine helps women with menopause, why do so many, because we have a lot of ladies with menopause.
Yep.
Almost all of them
going through menopause.
Yeah, almost all of them come to us after being really frustrated with not getting the help they wanted from conventional medicine. Why is that?
So in the late 90s, there was this huge study, the Women's Health Initiative. And up until that point, like in the 60s and the 70s, a lot of women were put on estrogen somewhat routinely. And what happened with this Women's Health Initiative, it was kind of a retrospective study looking at it was older women, I think over 65. And what the conclusion was that women on HRT had a higher risk of breast cancer and a higher risk of getting a blood clot, therefore increasing risk of cardiovascular disease. And so pretty much overnight, thousands of women were taken off HRT. And that's what we were taught in medical school, was it's not safe for most. It just wasn't prescribed. You just don't do it. And that is so basically that has been the mentality up until quite recently, and still is, I think, for a lot of people, especially maybe people who went through medical school years and years ago, like myself. So what happened for a lot of us is that we had to do most of our training after medical school, right? Like we had to do kind of a lot of the continuing education around hormone replacement therapy after, because it really wasn't baked into the curriculum. So women will go to their primary care doctors, sometimes even to their OB, to their gynecologists, and these doctors are either they're scared, there's fear, they've just been told you do not put women on hormone replacement therapy, and or they were just never taught how to prescribe it. It's just not in their wheelhouse, and so they don't offer it. And I think the right thing to do is to just own that and just to say, this is not my specialty, I don't know how to do this, and maybe help refer that woman on to somebody who does. Actually learn how to do it, do the training, put in the work. But what I hear more often is that the woman just feels dismissed, and that the provider, rather than kind of owning that they don't know something, will just put the woman on an antidepressant, tell her to lose weight, change her diet. She feels dismissed.
Mm-hmm. Yeah, like I hear you. And then a lot of them too are put on things like antidepressants, laxatives, right?
Yep, exactly.
Meds they don't need. Yeah, I hear you.
And the interesting thing is that younger women, and even women into their 40s, are routinely put on birth control, oral birth control, and that the hormones in birth control is so much higher levels of hormone replacement than what we put on women going through perimenopause and menopause.
Oh, okay, gotcha.
Yeah.
What else is the difference, right? Because those are synthetic hormones, right? Those
are synthetic, and we prefer bioidentical. Bioidentical meaning that it's chemically identical to what our own hormones look like, as opposed to synthetic, which are similar but not identical. And the safety profile of bioidentical is higher. Yeah.
Okay. Real quick. Sorry. So I'm going to ask a question. It's going to sidetrack us for just a second. Okay. How bad is birth control? Like if you were, for moms out there with daughters, right? 16, 22, whatever. What are the long-term side effects of something like being on a super high dose of synthetic estrogen as a young girl for a long time?
I think, again, everybody's different. I think sometimes it does feel like a necessary evil if a woman is having really severe menstrual pain, heavy bleeding, really irregular periods, and or if that's the only form of contraception that really makes sense, then it's the right thing to do. We also now have IUDs, intrauterine devices, the hormonal versions, and then the non-hormonal versions, and those can sometimes be a good option as well. It's a lower and localized dose of progestin or progesterone, synthetic progesterone. But long term, I think one thing is that I think for some women it can affect fertility in the long term. Not all, and probably not the majority, but I think it can impact fertility down the road if somebody's been on it for 10 to 20 years. I also just think that in some way, I think girls and women are meant to cycle, and so if you're taking a synthetic form of hormone that is making you not cycle at all, I do think that I think, again, when that is going on for 10 to 20 years, the body can sometimes, it can just kind of forget how to cycle on its own. It can take a while. For example, if a woman has been on oral birth control, it can take her a while to conceive because the body, she doesn't really remember how to do that normal monthly cycle.
Heard. Okay. Gotcha. All right. Back to.
Birth control does increase your risk of blood clots. So, for example, if you smoke, you should not be on birth control.
Okay. Gotcha. Smoke anything?
Nicotine.
Okay.
Nicotine, cigarette, yeah, because both increase your risk of blood clots. So, the synthetic estrogen increases your risk of blood clots, and smoking increases your risk of blood clots. So, neither one is great, but you definitely don't want to do both.
So, what about all the girls in college who are on birth control and vaping? Are they screwed?
Not great. I would say, I would say, so this is oral estrogen, and that's one of the negatives. That's why an IUD is a better option for a lot of young women.
Mm-hmm. Okay. Back to menopause. Okay. What are some of I guess we kind of already asked that about we all asked this. What are some of the biggest myths or misconceptions about menopause that you hear from patients where they have limiting beliefs?
It's what we've all been, what was kind of put out, which is that it's not safe, and that it's going to increase risk of breast cancer, which it is not. Transdermal or topical estrogen, which is bioidentical, is actually recent studies shows that it lowers your risk of breast cancer as well as colorectal and lung. Or increases your risk of cardiovascular disease because of the risk of blood clots. What happened with that Women's Health Initiative is that we now know that those results were misinterpreted, and so basically there's just been misinformation out there for decades. So actually maintaining a serum level, a blood level of estrogen, for a certain number of years reduces your risk of cardiovascular disease. And so there's a big difference in terms of the amount of estrogen and whether it's transdermal, meaning topical, versus oral.
Gotcha. Is there ever a scenario in menopause where you don't recommend bioidentical hormone replacement therapy for ladies?
Technically, if a woman has had a personal history of breast cancer, we would not recommend estrogen. Now, vaginal estrogen is safe for literally any woman or any person with a vagina. If somebody, again, family history of breast cancer, it's fine. If a woman has a personal history of breast cancer, it just needs to be, she needs to be provided with a lot of information and understand the risks. And if there's, really clear reasons why this person She's having really debilitating hot flashes, other vasomotor symptoms like night sweats, then it can be a personal decision between her and her doctor. Progesterone, oral progesterone, totally safe. Topical testosterone, totally safe. It's really so that's one person that, or a clotting disorder. If she has a tendency for DVTs, deep vein thromboses, another clotting disorder, we might be a little bit hesitant to put her on a form of estrogen or estradiol other than vaginal.
Gotcha. Okay. Let's talk a little bit about hormone testing, because a lot of ladies are told that doesn't exist or it's not important. Can you kind of break the myths or give some truth to blood testing for estrogen, progesterone, testosterone, your sex hormones?
Yeah. So we do, it's part of our initial panel, and we do like to monitor blood levels of those hormones if somebody is on bioidentical HRT. What we see is that somebody's experiencing perimenopausal symptoms. Again, it could be the vasomotor, it could be brain fog, it could be just poor sleep, it could be weight gain, could be low libido. We're not going to see that in the perimenopausal time frame. We're not going to see that directly reflected in the blood work, usually, right? If a woman is still cycling, that's what we're going to see on the blood work. We're not going to see usually blatant imbalance in the blood work, but it does give us a baseline for when we do start to give her potentially hormone replacement therapy. Now, if a woman is postmenopausal, I can tell right away based on the blood work, right? I can tell she's not making progesterone, she's not making estrogen, her follicle stimulating hormone is high. So again, it's a baseline and it can be used as a way to monitor or manage treatment. But so that's why it's good to test. It's certainly not imperative, because really what we're doing is we're adjusting doses. We're finding the right forms for that woman based on clinical symptoms.
Gotcha. Clinical symptoms being, what are the main symptoms?
How does she respond? So a woman, for example, the simplest is maybe oral progesterone, wakes up between 2 and 4 a.m., is, tired, has brain fog, largely because of the poor sleep. We put her on progesterone, oral progesterone, which is really the relaxation hormone. And she's able to sleep more. She therefore feels better. That's more important to me than getting a certain lab value on her follow-up labs. I want to see what the lab, what we're, I want to see it, but more important to me is what she reports.
Gotcha. Is there a connection between cortisol, so that stress hormone, and menopause?
Yes. I think you've heard me say this before. There is that triangular relationship between the ovaries. So the sex hormones come from the ovaries, the adrenals, cortisol comes from the adrenal glands, and the thyroid. And they're all interrelated. They're all part of the endocrine, the hormonal system. It's not a linear relationship. If there's high stress, which will dysregulate cortisol, it doesn't necessarily mean somebody has high cortisol. It could be high, it could be chronically low, it could just be kind of out of whack. That is going to most likely or can impact both the thyroid and or the sex hormones. So it's a little kind of complicated in exactly in how it does that, but in the same way, say a woman's progesterone is, she's in perimenopause, she kind of, her progesterone is a little bit low given what her needs are at that time. She's not sleeping well. She's not handling the stress in her life very well, that is going to therefore impact cortisol. So again, it's kind of everything's interrelated. Yeah.
Gotcha.
Including,
Okay.
including the thyroid, including overall metabolism.
Gotcha. With that said, everything being interrelated, when a patient comes in with menopause or is postmenopause or perimenopause, how often are you obviously you're looking at everything, but how often are you actually creating a plan that also supports their thyroid and their gut health and their sex hormones? Is it always you're looking at all three of
I'm
those?
always looking at all of that. I'm always asking, I'm looking. So again, our initial panel includes cortisol, includes a full thyroid panel, includes a full sex hormone panel. So in one glance, I am able to kind of get at least an initial look at the status of those. And then by extensive questioning, I can find out the gut health. Is she constipated? Is she bloated, et cetera? So in my head, at least, I'm always looking at all of it. I ask about sleep. I ask about life stressors. I've asked somebody, how do you handle, not just what are the stresses in your life, but what's your stress resilience like? How do you handle stress? So I'm at least starting to form an idea. And depending on the person, we might kind of attack all of that at once. We might bring in things to help with constipation. We might bring in things, some hormone replacement therapy, including maybe some thyroid replacement or some other nutritional things to help support the thyroid. It's personalized in a lot of ways, including someone's acknowledging or recognizing someone's bandwidth. Some people come in and they are gung-ho and they are ready to do all of that. A lot of people are really overwhelmed as it is, and we need to take things kind of step by step. So that's part of the conversation. It's a really crucial part of that first visit of like, what's the best way in here? What's going to give this person relief the soonest, and where can we just at least start to move the needle? And we will get to these other things. But I always say to people, I don't want you to leave feeling like your head is spinning. Like, I could recommend 100 things. They're all appropriate. It's just going to probably be too much for you. We just need to start somewhere.
Gotcha. It's a good approach. What can women do prior to menopause to make it easier for when that does happen, where they're not as affected, if anything at all?
Prior to perimenopause or menopause?
Well, it goes perimenopause, menopause, right?
Yeah.
Yeah, just all of it.
Well, circling back to the gut, I mean, I think, having regular healthy bowel movements is crucial. Working on ways to maintain a low level of inflammation system wide is also going to be beneficial. So if inflammation is high going into perimenopause, that inflammation goes up for a lot of women in perimenopause. So if your baseline is already really high, and again, you're not detoxing well, you're not kind of processing everything through the liver, including sex hormones well, then then perimenopause happens. It's like adding more fuel to that fire. So if you can optimize your baseline before perimenopause, and it's kind of boring, but it's still true. Nutrition, like optimal nutrition, relatively low sugar diet, lots of fruits and vegetables, high protein, and moving your body regularly, sweating regularly, all of the things that we know we should do. Well, it's still true. Lifestyle choices do really matter. Then when you kind of get this added piece of perimenopause, you're going to probably be able to handle it better. It's almost like the load, right? It's like, what's the load? And so if you're kind of like your cup is already kind of full with these physiologic stressors, it's going to be much harder when you add that perimenopausal piece.
Heard. Okay. So talk a little bit about weight loss in menopause. How come so many women hit, 40, 50, 60, probably more 50, 40s, and like
Mhm.
weight starts coming on. It's so hard to lose weight. Is that menopause? And then if so, how does menopause directly, make it hard to lose weight?
Yeah, it's a big part of it. I mean, it's the drop in estrogen is a big part of it. I was reading an article about this yesterday or the day before, and they were also saying that we now know that like even some of those hormones like ghrelin and leptin, those hormones more on the gut level, those are impacted by a drop in estrogen, and women are often hungrier than they used to be. And so that satiety level of how quickly you are full, that shifts. So a woman might not even, she may or may not realize that she's actually eating more. So you both have kind of a downregulation in metabolism. So oftentimes hypothyroidism kicks in. So your metabolism is lower, your estrogen is lower, and you might be eating more. We talked a little bit about cortisol. If cortisol is dysregulated, there's emotional eating. So there's all different things that can kind of play into it. But it's super common because of all those things, for women to gain weight, often in the midsection.
Gotcha. How often are you like putting women on estrogen and then all of a sudden they lose weight? They start losing weight again for like the first time.
Wow. Yeah, it commonly, it's not, if a woman needs to lose 100 pounds, she's going to need some things in addition to estrogen replacement. But it definitely can be an important part of the plan.
Mm-hmm. Gotcha. Okay. Let's see here. Going over. Those were all my questions. And what else would be important for, a woman to know about going through menopause and making sure that they have the best health possible?
I think just to kind of reiterate that even though it's like a normal stage of life, perimenopause is actually often harder for a woman than menopause, because there's these fluctuations. It's unpredictable. And for a lot of women, after menopause actually hits and you kind of fall off the cliff, kind of emotionally, and sometimes it's actually easier than the volatility of perimenopause. But I guess I would say that even though it's not a medical pathology, that it can be life-changing to be on hormone replacement therapy. And it doesn't mean that it's not a failure. Like, you can still do all the work. Like, you can still work on your nutrition and your exercise and do all the things that you've been doing. And it's like, it can sometimes be just a really great support and a tool. And what I like to tell women is, you're doing it for your current self, your current body. But as I listed earlier, there's these really incredible statistics about what it prevents. And so I say, you're gifting your 63-year-old self, your 73-year-old self, your 83-year-old self. The earlier you are, like late 40s, early 50s, if you give yourself this kind of gift, you're going to reap the benefits you're going to have a lower risk of fracturing your bones, because your bone mineral density is going to be higher. If you go on vaginal estrogen, you're going to lower your risk of UTIs, which basically puts people in the emergency room every day. You're going to decrease your risk of cardiovascular disease, like all these things, even reduce your risk of dementia. And so I think it's a conversation and it's information I like any woman between the ages of 35 and honestly 75 to have. Doesn't mean every woman should be on hormone replacement therapy, but every woman should have the education around it and have the information and make the informed decision herself. It should be on the menu.
Gotcha. Let's talk about some of the older ladies out there, way after menopause. What are the best options for them? How often are you putting
So
ladies over 60
traditional, yeah.
HRT?
Up until recently, and still kind of the old school of thought, was if a woman was 10 years postmenopausal and or over 65, that because of this idea that we were increasing the risk of blood clots, that we were therefore increasing her risk of having a cardiovascular event like a stroke or a heart attack, that you would not put a woman on hormone replacement therapy. You would not put her on estrogen because of that. And that has recently been refuted. Again, using topical, what we call transdermal estrogen. The risks are so low of a blood clot and therefore increasing cardiovascular disease or an event that oftentimes the benefits outweigh the risks. The benefits of, you can still improve bone mineral density, you can still decrease risk of dementia, even if a woman is in her 60s and 70s. And just to be a broken record, vaginal estradiol is safe for everybody. And often it's that population that is dealing with vaginal dryness, pain with intercourse, and really kind of maintaining the health of that vaginal tissue is pretty significant. And again, safe for anybody, any female.
Gotcha. So what are the options out there? Going through, you're noticing some hormonal changes, you're going to your primary, they're referring you out, they're not helping. What is a patient's options?
Well, ideally you come to a practice like this, where this is what we do, day in and day out. And we have, we have the right testing, we have options, and can kind of provide education. There is, you have to be a little careful going online, but there are people kind of providing good information around women's health, around menopause medicine, and doing kind of your own research. But ideally, you do find a provider that can work with you and your specific history, your goals. That's, again, I like to use the term personalized medicine, customized medicine, because what might be working for your girlfriend or your sister might not work for you. And that's again why we do testing and why we spend so much time with our patients, so that we can come up with an individualized plan.
Gotcha. Cool. Last thing, because I always like to ask this question: how many women you probably see multiple women every day dealing with hormonal imbalances, right?
Yeah.
Okay. Can you give one of your favorite patient case studies of a lady who came in dealing with hormonal changes and maybe had been dealing with them for a while, and then with, kind of like what type of plan got her back to feeling like herself again?
Yeah. So let's see. I saw a woman yesterday who, pretty common scenario. I think this was the third visit that I'd had with her. And I usually meet with people every 3 months. So when she first came, she had been kind of trying, again, had done her own research, felt like she had some hormonal imbalances, was kind of looking for someone to help her with potential hormone replacement therapy, had tried primary care, had, again, been dismissed, told that she just needed to lose some weight and she would be, that was kind of all she was told. Didn't have much luck either with her gynecologist. Did some research, found us, and still cycling. So 45-year-old woman, still cycling, and had actually missed a period for like 9 months, but then had one. So definitely perimenopausal, right? You have to have technically 12 months without a period to be menopausal. And I could also tell from her initial blood work that her ovaries were still producing some estrogen and progesterone.
Mhm.
So, again, this was 6 months ago. We started her on oral progesterone, a estrogen cream that's called Biest. It's a combination of estradiol and estriol, two different forms of estrogen. So it's a cream she applies every day. And when I saw her 3 months ago, she had some improvement. So she was feeling some improvement with sleep, wasn't 100%, and had not noticed a change in her hot flashes or night sweats. So 3 months ago, I increased the dose of the oral progesterone, and I increased the dose. We tend to like to start low and slow, right? Like lowest amount possible of hormone and see how somebody responds. Everybody has different levels of sensitivity. I basically bumped up the dose of both. And so increased with the creams, it's really easy because we use compounding pharmacies to be really specific in the concentration of estrogens. So I increased those 3 months ago, increased the oral progesterone, saw her yesterday, and her sleep, she hasn't slept this well in years. She's sleeping quite well, sleeping through that 2 to 4 a.m. time, which is oftentimes when women in perimenopause are going to be waking up. And her hot flashes are few and far between. She's still having them, but again, it was like when she came, it was probably multiple times a day. And now it's maybe once a week she'll have a hot flash. And her, we're doing blood work throughout and everything looks totally normal on blood work. So it's really safe. It's not that complicated. And this woman just feels so much better. It's great.
Man, what a good story. I mean, it's really scary actually to think about like what if she hadn't done anything and she just kind of was, said, all right, this is how it is. When the reality is she actually could feel a lot better again with some more functional help. So it's really exciting. We get to do that every single day.
Yeah.
So, if you're watching this or if you're watching a recording of this and you're interested in becoming a patient, you can go to medmatrixusa.com. And you can click get started and book a time with a patient coordinator. And we would absolutely love to talk to you and see if we can help you reach your health goals. But with that, that's time for today's episode. Dr. Rose, thank you so much for joining and educating us all. Always so much fun. And we'll see you in the next one.
Thanks.
Oh, real quick, before everyone who's live goes, just so you know, it is next Thursday at 4:30. We're going live with Dr. Anand and Dr. Rose, and we're going to be talking about functional medicine. We're going to be talking about long haul COVID. So two really exciting hot topics, as well as doing some Q&A. Hoping to do some more kind of panels with Dr. Rose and Dr. Anand as the future goes on, things like POTS and all these other various issues that patients come to us with. Really exciting one. So I would actually put this on your calendar. We're going to be sending out some emails. And that's it. Dr. Rose, anything to add before we hop off?
I don't think so. I thought it was this Thursday. Is it this Thursday or next Thursday?
This Thursday. Yep. 4:30.
It's this Thursday. Okay.
1/8. Yep.
Okay. Great.
Cool.
No, great. Thank you.
Awesome. All right, everyone. Thank you so much.